All, we are going to start our next award session. Judges, please note our first presenter is Dr. NEENA. Dr. NEENA R.
Very warm good afternoon to one and all, respected judges and my dear colleagues. We all know that thyroid eye disease is the commonest cause of proptosis and extraocular muscle enlargement in adults. And apart from orbital changes and dysthyroid optic neuropathy, it produces cosmetically disfiguring strabismus with intractable diplopia. About 15% of all patients with thyroid eye disease develop strabismus in the acute inflammatory stage due to hypertrophy of the muscles, and later in the chronic inactive stage due to fibrosis. So my aim was to analyze the clinical profile of strabismus in patients with thyroid eye disease and to evaluate the management options. So why did I do this study? Because there is a paucity of studies on the prevalence and profile of strabismus in thyroid eye disease patients from India. So this was a retrospective electronic medical records analysis of thyroid eye disease patients with strabismus or diplopia coming to our center from 2020 to 2025. Apart from the demographic parameters, we looked into the details of the squint, muscle involvement, thyroid status, antibody positivity, radiological signs, ocular and systemic comorbidities, and risk factors like smoking. We also looked into the treatment undertaken by each patient. Coming to our results, we had total 51 patients, 35 males and 16 females. The mean age was about 60.94 years, much more than the literature reported age of 40 to 45 years. Right eye was most commonly involved. Bilaterality was seen in about 49%. Asymmetricity was seen in 45%, causing an intractable diplopia in patients. Hypothyroidism was the most common status in 64.7% and most presented in the chronic phase. 82.4% presented with diplopia. Vertical strabismus was the most common presentation with hypotropia and elevation restriction, the commonest presentation in 47.1%. Post-duction test was positive in 97% patients. TRAB antibody positivity was noted in 35.3% patients. The most common muscle enlarge was inferior rectus, and radiological correlation was obtained in 60.78% patients. Dysthyroid optic neuropathy was seen in about 9.8%. 2 patients had associated ocular myasthenia gravis. Smoking was noted in 35.29% patients. So one of our patients, the youngest patient of 28 years old with hypothyroidism and TRAB antibody negativity, developed thyroid eye disease about 2 years post-treatment for papillary carcinoma thyroid. He had undergone total thyroidectomy with radioactive iodine ablation, and we presume this induced radiation damage of thyroid follicular cells led to deterioration of autoimmune reactions against the antigens which are common to the thyroid and orbit, leading to thyroid eye disease. And we learned an important lesson that thyroid eye disease can occur along with or even after treatment of papillary carcinoma thyroid. So results were also analyzed. Coming to the management of diplopia and squint, prisms were given in about 54.9% patients, frenal prisms in majority. Botox was given in a single patient. Squint surgery was undertaken in 15.7% patients, and the most common surgery performed was inferior rectus recession. 68.6% patients had relief from diplopia with the treatment, and the surgical parameters were decided on the status of the post-duction test, imaging showing the muscle enlargement, and the amount of deviation in primary gaze and down gaze. Coming to some patients, the patient on this left had a tight superior oblique in the right eye, presented as Brown syndrome. You can see here. And she had an enlarged superior oblique muscle in the right eye. She did well with steroids and prisms. So this was in contrast to the literature where oblique muscles are rarely reported to be involved. We had 2 patients with a Brown syndrome kind of presentation. Another patient who's doing very well with frenal prisms is in the lower picture. Hypotropia with enlarged inferior rectus was the commonest presentation. As you can see in this lady with a large right hypotropia, enlarged inferior rectus muscle, did very well after weakening of the inferior rectus by recession. Another gentleman with hypertropia and enlarged inferior rectus not only had to have an inferior rectus weakening, but we also did a tightening of the antagonist, that is superior rectus plication. In contrast to reported literature where plication procedures are contraindicated, we didn't have any issue. Another common presentation was hypertropia and esotropia, where inferior rectus and medial rectus were weakened, and patient did extremely well with good cosmesis and diplopia-free outcome. We had 15.7% of patients with hypertropia presenting with tight superior rectus, as you can see here, and these were all men with severe form of thyroid eye disease and were all smokers. So this patient after pulse steroid therapy is doing better and is awaiting squint surgery. So we observed an interesting effect of orbital decompression on squint. This lady had presented to us with a very small hypertropia and esotropia initially. Because she had dysthyroid optic neuropathy, she had to undergo endoscopic two-wall inframedial orbital decompression and see what happened to her squint after 4 months. It worsened. Why? If you look at this defect, you can see that the medial rectus has even become larger. It has herniated into the medial defect, and the inferior rectus has also herniated into the defect. So what did we learn? An unbalanced asymmetrical orbital decompression can actually worsen ocular motility and increase diplopia and squint due to changes in the orbital volume and glow position. So a balanced decompression is always better. So finally, she got it straight with squint surgery. We did weakening of the inferior rectus and medial rectus and application of the lateral rectus, and she did extremely well. So what did we find different? We had more male patients in our study as compared to the literature reports. Our mean age was at a higher age of 60.94 years. The biphasic pattern was also at a higher age. And the risk factors were same as seen in literature. But most of the patients needed a second stage surgery. Weakening was done in the tighter muscle, but plication could be done in the antagonist if there was no involvement radiologically and clinically. And 16%, 6 patients of the patients did very well after plication. So to conclude, vertical strabismus with inferior rectus involvement in males with hyperthyroid status and a higher mean age was the commonest presentation. Recession could be done with good cosmesis and functional outcome. Staged surgery is often needed. Plication can be done provided there is no clinical or radiological involvement, and prisms are useful both pre and post surgery to correct the residual squint. Thank you.
Yeah, very nice presentation. Just two simple questions. Any particular reason why we have more common involvement of inferior rectus and less common involvement of lateral rectus and obliques? And secondly, what was the incidence of compressive optic neuropathy in your series?
So the first question, inferior rectus is more often involved in thyroid eye disease because of its peculiar vascularity and gravitational effect. Because it's a bulkier muscle and because of the effect of vascularity, increased vascularity to the inferior rectus, more changes are observed typically in inferior rectus. Second would be in our series, we had about 9.8% incidence of dysthyroid optic neuropathy.
Very nice presentation, Neena.
Thank you.
Yeah. No, just to continue what Dr. Bala asked, did you have, so you said what percentage had optic neuropathy?
About 10%,
Just
9.8%.
9 to
Yeah.
10%. So did you have to treat both simultaneously in any of these, or for some patients did they require orbital decompression, following which you had to do squint?
Yeah.
Did you
So the
have-
surgery was done always when the disease was inactive, and dysthyroid optic neuropathy almost always presents in the active phase. So we had to give pulse steroid therapy to the patients, and if they were not improving, some of them had to undergo orbital decompression, as I showed. And the squint in the interim period was tackled either with prisms or with steroid therapy. And when the disease was inactive and they went into a chronic fibrotic stage, that is when we undertook them for squint surgery.
Just another quick question. So you said about 68% of them responded, right? So what happened to the rest? How did you manage the rest of your
So
patients?
it's a very complicated strabismus because sometimes with a single surgery you don't get results, and some of them are scared to undergo surgery because some of them have had thyroidectomies, they've had orbital decompression. So there was this one patient, we had to convince her a lot to undergo squint surgery because she said, I underwent orbital decompression. You said I will be okay, and now my squint has worsened, and how do I believe you? So these were kind of questions. So it's in literature also the response to treatment is about 70%. So because of multifactorial reasons, and always a staged approach is recommended.
Good. Yeah. Thank you, Neena.
Thank you very much.